In the world of lichen sclerosus, there's this one specific tool, and it causes, well, arguably the most anxiety.
Oh, absolutely.
And it's exactly 4 millimeters wide.
Just a tiny thing, yeah.
Right. So today, we are looking at why a skin sample that is literally smaller than a pencil eraser holds the absolute key to your lifelong health. Welcome to this deep dive.
It's an intense topic, I know.
It really is. I mean, you already know the anxiety of managing this condition day to day. You know, the symptom tracking, the standard treatments, the constant vigilance.
It's exhausting.
Yeah, totally. So today, we're taking your specific concerns about the biopsy process, pulling from this massive stack of medical guidelines, NHS patient leaflets, pathology
It's a
research,
huge stack of paper.
so much reading.
Yeah.
But our mission is to completely demystify what an LS biopsy involves. From the exact biological mechanics to the lab analysis, so you can walk into that clinic room completely empowered.
Okay, let's unpack this.
I love that because it's a profound shift in your medical journey, When you're managing LS, you get used to a routine. All right, the creams, the checks.
Exactly. But the word biopsy, it just introduces this sudden, sharp interruption to that routine.
That's a scary word.
It is. We're moving from simply managing a known condition to actively hunting for cellular changes and understanding the how and why of that hunt. Well, it transforms it from a terrifying ordeal into a really fascinating, highly controlled medical intervention.
Yeah, knowledge is power. So we know the standard drill with LS, right? Your doctor spots the classic signs. You get the clinical diagnosis.
Usually just by looking.
Right, just visually. And then you start the standard 6-week trial of ultra-potent topical steroids. The goal is to halt the inflammation, get it into remission. But what happens when that trial fails?
Yeah, or what if the visual symptoms just don't perfectly align with the textbook?
Exactly. That failure to respond to treatment, that's the primary friction point. That is when the biopsy punch enters the room.
And this raises an important question, why do it at all? The clinical guidelines actually treat the biopsy as an escalating tool.
Like a last resort.
Well, used only when absolute certainty is required. If your symptoms are classic, taking a piece of tissue is actually discouraged.
Just to save you unnecessary discomfort.
Right. But when we encounter diagnostic uncertainty, the stakes completely change. Sometimes LS overlaps with other inflammatory dermatosis.
Like lichen planus.
Exactly, lichen planus, which requires a slightly different management approach. Or there might be an atypical presentation that mimics, a severe, deeply rooted fungal infection.
So they just can't be sure just by looking.
Right. The doctor cannot rely solely on visual inspection if the tissue isn't behaving predictably.
And beyond just the confusing presentations, there is this specific trigger that prompts, I think, the most anxiety for anyone listening, the cancer risk.
Yeah, we have to talk about that.
We do.
Yeah.
And the sources do not sugarcoat this, but they do frame it as a manageable metric. In women with vulval LS, there is up to a 4 to 5% lifetime risk of developing squamous cell carcinoma, or SCC.
And there's a corresponding, albeit smaller, risk for men developing penile cancer, too.
Right. So when a doctor sees a persistent area of thickened skin, or a deep fissure that just won't close, or a new nodule, they're no longer just looking at inflammation. Right?
No, they are looking for cellular dysplasia.
Dysplasia. Okay, break that down for us.
So dysplasia is the critical concept here. Chronic, uncontrolled inflammation over years can force the skin cells into this state of hyperturnover.
Like they're reproducing too fast.
Exactly. The cells are constantly repairing themselves, and every time a cell divides, there is a microscopic chance for an error in its DNA.
Oh, wow.
Yeah. And over time, those errors can accumulate into what we call differentiated vulvar intraepithelial neoplasia.
That's a mouthful. DVN, right?
DVN, yes, which is the immediate precursor to squamous cell carcinoma. And a visual exam cannot see DNA errors.
Right, because it's microscopic. It's like a classic car, right?
Oh, I like this.
Yeah, usually you know a Mustang when you see it on the street. It's obvious. But if the engine is making a grinding noise, or it's not running right, even after tune-up, which is our steroid treatment, you absolutely have to pop the hood.
Yes, the biopsy is popping the hood.
Yeah.
A doctor cannot look at a patch of skin and determine if the cells at the very base of the epidermis have begun to mutate. The only way to see that is to extract the cells, dye them, and put them under a microscope.
Which brings us to the moment that 4-millimeter tool actually comes into play. Let's set the scene. You're in the outpatient clinic. You undress below the waist, take your place on the examination couch, usually with padded leg supports.
It takes about 15 to 30 minutes usually.
Yeah, super quick. But I found it incredibly reassuring reading through the patient advocacy resources. They really highlight your absolute rights in this environment.
Oh, like having a chaperone.
Yes, you have the explicit right to request a chaperone, whether that is a carer, a partner, or a dedicated nurse whose only job in that room is to stand by your shoulder and monitor your comfort.
And medically, having an advocate in the room actually lowers cortisol levels.
Really?
Yeah, which physically reduces pain perception.
That is wild.
It's true. So once you're positioned, the physician does not immediately reach for the instruments. First, they perform a tactile examination.
Like feeling around?
Right. They're palpating the tissue, applying gentle pressure across the affected area. They are feeling for fibrosis or firmness underneath the surface.
Because they're looking for that specific mutation.
Yes. Precancerous changes often create a dense, hard cellular architecture that feels distinct from normal pliable skin, or even from standard LS scarring.
So they are essentially mapping the terrain by touch to find the most active, dense site. Because if they just guess and take a sample from a dormant area,
The lab results will come back totally clear.
while a dangerous mutation could be sitting just 2 millimeters away.
Exactly. It's a game of precision.
Okay, so once they identify that exact nodular spot, we arrive at the numbing phase, the injection. Now, the guidelines constantly refer to this entire process as a minor procedure.
Oh, I know where you're going with this.
I have to push back. I have to stop and point out that if you are the one on the table getting a needle in an incredibly highly innervated, intimately sensitive area, minor is the absolute last word you would use.
You are 100% right.
It is a majorly sensitive event.
The medical terminology severely downplays the patient's lived reality. The genital region has an exceptionally high density of nerve endings, making that initial injection objectively painful.
Yeah, it stings, right?
It does. The fluid used, typically lidocaine, is slightly acidic compared to human tissue.
Oh, I didn't know that.
Yeah, so when it enters the subcutaneous space, that acidity causes a sharp burning sensation for about 30 to 60 seconds.
And then it goes numb.
Right. Then the chemical actually binds to the sodium channels in your nerves and shuts off the pain signals entirely.
Okay, but to combat that initial acidic burn, I read about this brilliant clinical trick some specialists use.
What's fascinating here is how simple it is.
Yes. They apply a thick layer of topical lidocaine cream and cover it with a tiny piece of occlusive dressing, literally like saran wrap.
Saran wrap, yeah.
Mm.
For about 15 minutes before the injection.
And that forces the skin to absorb the cream rather than letting it evaporate.
Rigidly. It essentially deadens the very top layer of the skin so you don't even feel the initial prick of the needle. It is an elegant use of basic chemistry to improve patient comfort.
I love that. And once the anesthetic takes hold, this is where you must advocate for yourself.
Yes, speak up.
The physician will test the area, usually by tapping it with a blunt instrument. You feel pressure, the sensation of weight, but zero sharp pain.
Zero.
Yeah.
If you feel anything sharp, you must vocalize it immediately. The lidocaine only takes moments to top up.
Yeah, there's no clinical benefit to grinning and bearing it. Do not be a hero.
Definitely not.
So with the area fully numb, the doctor utilizes the punch biopsy tool. Now, I think a lot of people assume a biopsy is just a scrape, like taking a swab.
Oh no, not for LS.
Right. The sources are adamant that a shave biopsy, where they just scrape the top, is entirely insufficient for lichen sclerosus.
It misses the whole picture.
Exactly.
Yeah.
We can think of the skin like a geological soil sample. The epidermis is your topsoil, the dermis is the subsoil, and the hypodermis is the bedrock. A shave biopsy just scrapes the loose topsoil away.
But LS is a condition that fundamentally alters the deeper architectural layers.
Right. It's skin deep.
So the punch tool, it's this tiny circular hollow blade.
Kind of like a tiny apple core.
Yes, exactly like that. By applying downward pressure and twisting, the physician cores out a perfect vertical cylinder of tissue, less than half a centimeter.
Wow.
And if we connect this to the bigger picture, this core sample captures the epidermis, the entire dermis, and extends into the subcutaneous fat. This depth is non-negotiable.
Because of the scarring.
Right. The scarring characteristic of LS, the homogenization of collagen, happens in the upper dermis. If the pathologist only receives the epidermis, they are looking at an incomplete puzzle. They can't definitively rule out DVIN.
That makes perfect sense. So what actually happens to that tiny cylinder of skin once it leaves the clinic? because this is where the science gets genuinely fascinating.
It really does. It doesn't just get thrown under a magnifying glass.
Right, it's a whole process.
The tissue is immediately placed in a fixative, usually formaldehyde, which instantly halts any cellular degradation.
Freezes it in time.
Exactly. Once it arrives at the pathology lab, it is embedded in a block of paraffin wax to make it rigid. And then a technician uses a microtome, which is essentially an incredibly precise microscopic deli slicer.
A microscopic deli slicer. That's a great image.
It cuts ribbons of tissue that are literally a single cell thick. These ultra-thin ribbons are mounted on glass slides.
But wait, skin cells are mostly transparent, right? So the pathologist can't see the mutations just by looking at the raw slice?
No, they have to dye it. They use a process called H&E, staining hematoxylin and eosin.
Okay, hematoxylin and eosin.
Hematoxylin dyes the nucleus of the cell dark blue, while eosin dyes the surrounding cytoplasm pink.
Oh, so it color codes the cell parts.
Right, so when the pathologist looks through the microscope, they are specifically looking at those blue nuclei in the basal layer of the epidermis. In healthy tissue, the nuclei are uniform and orderly.
And in the precancerous tissue?
In tissue with DVIGN or early cancer, those blue nuclei appear enlarged, hyperchromatic, and chaotic. They are looking for visual chaos at the microscopic level.
That structural blueprint is what gives you definitive answers.
Precisely.
Meanwhile, back in the clinic room, you are left with a 4-millimeter hole that needs to be sealed. The doctor has a few options to achieve hemostasis or stop the bleeding.
They might use a special paste or 1 or 2 tiny dissolvable stitches.
And those stitches take, what, 7 to 10 days to disappear?
Yeah, about that. Or they might use a chemical medical device called a silver nitrate stick.
Okay, I have to say silver nitrate is fascinating.
It really is. It looks like a long matchstick.
Right, and when it contacts the moisture of the open wound, it triggers a localized instant chemical coagulation.
It's basically magic. It rapidly binds the proteins in your blood and tissue, essentially creating an artificial, sterile scab in seconds.
Wow.
It seals the blood vessels shut, preventing both bleeding and immediate bacterial entry.
So the entire procedure takes maybe 20 minutes, and you walk out the door. But the physiological recovery is just beginning.
Yes, the clinic visit is over, but the healing journey starts now.
Within an hour or two, that lidocaine blockade is going to wear off, and those densely packed nerve endings are going to wake up. And the clinical advice for managing this aftermath is highly specific.
It is. Over-the-counter painkillers are recommended. You are advised to take paracetamol or ibuprofen, but the guidelines explicitly warn against taking aspirin.
Why aspirin specifically?
Aspirin operates differently than other anti-inflammatories. It permanently binds to your blood platelets, preventing them from clumping together.
Ah, so it stops clotting.
Right. We just discussed the importance of sealing that 4-millimeter hole. If you take aspirin, you strip your blood of its ability to maintain that seal, drastically increasing the risk of prolonged bleeding and severe bruising at the biopsy site.
Good to know. No aspirin. So the physical mechanics of wound healing dictate a strict set of rules for the next few weeks. For vaginal or vulval biopsies, light spotting is normal, requiring pads or panty liners.
But there's a total ban on tampons for at least 4 weeks.
Right, no tampons. You are also instructed to abstain from sexual intercourse for 2 weeks and to avoid heavy lifting, vigorous exercise, cycling, horse riding, swimming.
Basically anything strenuous.
Right.
And these restrictions are all about protecting the proliferation phase of wound healing. After the initial bleeding stops, your body begins building a new collagen matrix and forming microscopic new blood vessels.
Angiogenesis, right?
Yes. And this new tissue is incredibly fragile. The shear forces generated by cycling or the pelvic floor pressure from heavy lifting can easily tear that delicate new matrix apart.
Which sets you back.
Exactly. Tearing it not only delays healing, but restarts the entire inflammatory cascade, which is exactly what we want to avoid in a patient already dealing with an inflammatory skin condition.
Makes total sense.
Yeah.
You are also warned against soaking in baths or hot tubs for the first few days. Prolonged exposure to warm water makes dissolvable stitches soggy.
Nobody wants soggy stitches.
No. It causes them to break down prematurely before the underlying tissue is fused. Furthermore, public pools or hot tubs introduce a massive bacterial load to an open channel in the skin. So showers are better.
Yes, showers are recommended using only plain water. No soaps, no fragrance gels.
Why no soap?
Well, the pH balance of the healing skin is easily disrupted by the alkaline nature of conventional soaps. Maintaining a neutral, clean environment allows the epidermis to regenerate without chemical interference.
Here's where it gets really interesting for me. The bathroom hacks.
Oh, yes.
Easily the most brilliant practical advice hidden in these medical leaflets. Because passing urine over a fresh, chemically or surgically sealed wound
Yeah.
is going to sting aggressively.
Extremely painful. The salt and uric acid in urine act as an irritant to the exposed dermis.
And using dry toilet paper to wipe introduces both friction and the risk of leaving microfibers in the wound. So what do we do?
The standard protocol involves a peri bottle. You fill a specialized squeeze bottle with lukewarm water. As you urinate, you simultaneously spray the water over the biopsy site.
So it flushes it as you go.
Exactly.
Right.
The continuous flow of water dilutes the urine before it can chemically burn the raw tissue, and it mechanically washes the area clean without any physical abrasion.
Genius. Then we have the challenge of drying. You absolutely cannot take a towel and rub the area. Even gently patting dry carries a risk of bacterial transfer.
Right.
So several NHS and patient advocacy resources recommend a completely hands-free approach using a standard hairdryer set on the cool setting.
Utilizing a cool stream of air ensures the area is completely desiccated. Fungi and bacteria thrive in warm, moist environments, right?
For sure.
So by rapidly and thoroughly drying the microenvironment of the wound without physical contact, you drastically lower the risk of postoperative infection. It is a perfect example of translating medical necessity into everyday practicality.
I just think that's such a great tip. Also, during this acute healing phase, your regular LS treatment is altered.
Yes, you have to be careful here.
Your doctor will typically instruct you to pause the application of your ultra-potent topical steroids on the biopsy site for 3 to 7 days.
Because steroids inherently suppress the immune system and slow down cellular turnover.
Which is great for stopping LS inflammation, but terrible when your body is desperately trying to multiply cells to close a fresh wound.
Exactly. You have to allow the acute wound to seal before reintroducing the chronic treatment, and during this period, vigilance is required.
Watch for infection, right?
Yes. You are monitoring for pathological signs of infection. A spreading ring of erythema or redness, severe swelling, a sudden spike in body temperature, or a purulent, strong-smelling discharge.
Any of these require immediate clinical intervention to protect the integrity of the tissue.
Don't wait around if you see those signs.
Right. So what does this all mean? After all the numbing, the punching, the cellular staining, and the careful bathroom logistics, we return to the core purpose of this entire journey. You trade a few weeks of acute, highly managed physical vulnerability for definitive, unarguable data.
You really do.
The pathologist sends back a report that either confirms standard lichen sclerosus, allowing you to continue your management plan with confidence, or identifies those chaotic blue nuclei, catching deviant early enough that it can be completely excised before it ever becomes a life-threatening carcinoma.
The procedure removes the guesswork. It is the ultimate tool of medical self-advocacy. By understanding the mechanical reality of the biopsy, you are no longer a passive recipient of a terrifying procedure.
You're in control.
You are an active participant in securing your own long-term health outcomes.
Which leaves us with something really fascinating to consider about the future of this whole process. Think about it. Living with a chronic condition like LS requires constant, watchful waiting and self-examination. And right now, to get that definitive certainty and interrupt that waiting, we have to physically core out a 4-millimeter piece of your body.
It's invasive, yeah.
We have to look at the architecture of the tissue. But dermatological science is rapidly advancing into the realm of epigenetics and molecular profiling.
Oh, this is the really exciting stuff.
Right. Researchers are currently developing non-invasive tape strips and high-tech genetic swabs that can collect cells from the surface of the skin and analyze them for the exact RNA signatures of squamous cell carcinoma without ever breaking the dermis.
It's incredible to think about.
Imagine a near future where the anxiety of needles, the silver nitrate, and the weeks of careful wound management are entirely replaced by a simple, painless swab that offers the exact same diagnostic certainty. Until that day arrives, knowing exactly how and why the current tools work is your best defense against the fear of the unknown.